see the world through other people's eyes. Now, empathy is a quality of character that can change the world.
Hi, I'm Edwin Rutsch, Director of the Center for Building a Culture of Empathy, and I'd like to welcome you to our ongoing conference on how to build a culture of empathy and compassion. This is panel number 20, titled Empathy in Critical Care. And I would like to now turn it over to our panel moderator, who is Keonis Taylor, who is Executive Director of Comfort Homesake. Keonis?
Thank you, Edwin, for that introduction. Again, my name is Keonis Taylor. I am the Executive Director for Comfort Homesake. Comfort Homesake is a hospice organization. We operate with a mission that advances hospice through advocacy, education, and consultation. And today, we're highlighting one of the key themes in our work, which is empathy. And so we've we've partnered with Edwin and the Center for Building a Culture of Empathy to invite three distinguished individuals to this panel, Dr. Barbara Beach, Marilyn Aubagio, and Dr. Jody Halpern. And I'd like to ask each of them to say a little bit about themselves, but I'd first like to just speak a little bit about them to give them a brief introduction. Marilyn Aubagio began her career in the military and has been a successful business owner for over 30 years. She's a published researcher, presenter, and author on issues of ethnic diversity, environmental justice, and transportation. She became involved in hospice after the illness and eventual passing of a close family member. And she brought her skills and experiences together to found Comfort Homesake nearly 10 years ago. She now serves as the chair of the board of directors here, and she also is the hospice systems coordinator for Alameda County. Dr. Barbara Beach is the co-founder and medical director of George Mark Children's House. Dr. Beach has been a pediatric oncologist at Children's Hospital and Research Center in Oakland for more than 30 years. As a result of her clinical interaction with Dr. Kathy Hull in the 1990s, Dr. Beach's long-held building a hospice and palliative care center was realized with the opening of George Mark Children's House in 2004. She completed her pediatric residency at Children's Hospital and her specific hematology oncology fellowship at the University of California in San Diego. She also serves as the medical advisor for hospice and young people and comfort for kids. Dr. Jody Halpern is an associate professor of bioethics and medical humanities at the University of California at Berkeley in the Joint Medical Program in the School of Public Health. She is a psychiatrist with a background in philosophy. She investigates how emotions and the imagination shape healthcare decisions of clinicians and patients. Her work has had a long-standing focus on empathy, and she's the author of From Detached Concern to Empathy, Humanizing Medical Practice. She is a featured contributor of Huffington Post. So thank you, ladies, each of you, for being here. Thank you, Edwin, for helping to facilitate this panel. And I'd like to first start with asking each of you to say a little bit more about your experience and your would you like to start, Dr. Beach?
Well, I was actually hoping that Jody would give us a working definition of sympathy, empathy, and compassion, because I think that the definition of those terms may be somewhat different in the dictionary than the way that we think of those terms in our work and in our everyday life. I know that's true for me. So I don't know, Jody, is that appropriate to ask you to jumpstart
Sure.
us with definitions?
Okay, I'm happy to do that, and I have to say how honored I am to be with all the other panel members today. It's really very moving to me, the work that you've all done with your lives. And so I'll give you some definitions, and I'm a clinician also, but you've all been steeped in this work throughout your careers. So, and again, people can use these terms. It's really important that people just know what they mean. People can use words however they want. But I tend to use the word empathy very specifically for engaged listening, where your goal is really to learn more about how another person feels, what their world is like from their perspective, so that it's not just I always say to students, medical and nursing students, that the worst thing you can say to somebody is, I know how you feel. And the best thing you can say is, tell me what I'm missing here. I think that as clinicians, we're not encouraged to be curious enough and engaged curiosity. And that's very important. It's not just intellectual curiosity. It's affectively attuned. You're using all the normal tools that we have since childhood when someone tells us about their experience to really try to see what is salient or important to them about the specific issue, whether it's a certain kind of family visit they're facing, or pain or discomfort, or a goal or a wish for the future, to live a long enough time to see, a grandchild married, whatever their issue is, what's salient and important to them as opposed to what the medical system defines. So that's what, to me, empathy is seeking to really understand and imagine more vividly from the particular perspective of a unique individual. Each person is a world, and we're trying to enter into that using our feelings and our imagination. That's empathy to me. Sympathy, to me, is a very natural feeling that has a component of the same thing as empathy, which is affective resonance, where you suddenly feel yourself swept up in another person's feelings. And I think that helps get you on the first step to empathy, but you need the curiosity with empathy. With sympathy, you feel a sense of involvement in another person's feelings, but you don't necessarily use it in the service of curiosity. So I always say, if a friend comes home and says, my boss is terrible to me, in sympathy, I just totally take it on as an advocate and say, yeah, your boss is terrible. But in empathy, which I think clinicians use, I say, wow, it sounds like you're feeling terrible about your boss right now. And then I become curious, like, why today? What happened? I want to know more about the particulars, and I'm not just buying into it completely emotionally without also having an open mind to help them discover more about what's going on. So sympathy is a wholly affective. You're letting yourself get swept up in being in the same position with someone else, whereas empathy, you want to be moved by their situation, but you want to use it in the service of helping yourself and them learn more and think more about what's going on. And then compassion, to me, which is very important, I think, is more of a pan concern, where you're not so much focusing on one individual and their needs as deeply as with empathy, as much as helping them and yourself feel the common humanity, that we all suffer, we all die, we all are in this together in the sense of a broad, either Zen Buddhist or other religious or spiritual sense, that we're all humanity, and our capacity to suffer unites us. And that can really help relieve your own pain and suffering as a clinician.
Thank you, Jody.
Okay.
I just want to thank you, Dr. Beach, for moving us forward with that question. And I think that from there, I'd like to ask the three of you if you agree with those definitions of empathy, and if so, how those definitions make empathy relevant in the work that you do. And I ask that in the context of the fact that each of you come from very different backgrounds. And we chose the three of you for this panel because of the diversity in your backgrounds and in your work, in combination with the principle of empathy being such a powerful theme in the work that you do.
Well, I could jump in here. Because of the fact that my work is involved with children who are dying, that I think, how to state this, I think that empathy is a critical skill. It's a skill set. It's something that, if you're going to be effective in your work, I think particularly with children who are dying, clearly adults die as well, but for a variety of reasons, I think that children's death is a bit of a different, it requires a bit of a different skill set, I think, to do that work effectively. Empathy is absolutely critical, and I think part of the problem is that with empathy, you are more likely to put yourself into someone else's situation. Sympathy, yes, but I think that when you empathize with someone and you're doing that careful listening, Jody, that you spoke of, and you're really trying to get to what is going on and how you can be of help, it becomes I think, in a very personal way, difficult in some ways to separate yourself from the person who's going through that situation. And Jody, you said something that I hear from families all the time. I've probably worked with more than 100 families of children who either have recently died or who are dying. And parents say to me, the worst thing anyone can say to me is, I know how you feel. And the response from them is always, they don't know how I feel unless they're a parent who's lost a child. Then they have some idea of how I feel. But no one else can know really how I feel. And I was taught very early on never to say those words, and I never do. But I oftentimes will say to a family, I can't even imagine how you feel. I'm a parent too. This must be the most awful thing that could possibly happen to anyone. It's everyone's worst nightmare. What can I do to try to make that a little less awful for you? Some people would say a little better, but you can't make it better. But maybe you can make it a little less terrible. And families really respond to that. You know, they're very grateful for the support, for the empathetic listening, and for the concrete kinds of things that we can do in pediatric palliative care to try to make that experience not quite as awful as it could have been. And when people ask me, how do you keep doing this work year after year after year? My response is always, I feel that I make a difference. And as long as I'm able to make a difference, I'll keep doing what I'm doing.
Great, thank you. I'd like to hear from you, Marilyn, on this question. And I asked specifically in the sense of knowing your business background. I know that your experience is so dynamic, having the business background, having the personal experiences, then also having founded an advocacy organization. And I'd like you to just speak about a little bit about why empathy is relevant in all the work that you've done.
I was just thinking about that because, and I accept and appreciate the definitions Dr. Halperin just gave us. I was thinking about when I started my career in Washington, D.C., and working on Capitol Hill with legislators and staffers, and then working in the business community, and how we generally had the habit that we don't bring emotions into the negotiation. We don't bring emotions into the boardroom or in any kind of setting where I guess there's money involved or power. So from that point of view, I didn't use a lot of them. A lot of the information, resources, and effort that I put out was really focused on goals and objectives. And it wasn't until I had the experience of actually being at the bedside at a transition and being a spiritually minded person, this experience, it brought something out of me. It gave me a real understanding of the fact that life to death is a transition. And there's something about that transition, something that's in that transition that is surreal. There's a beauty in it that struck me so profoundly that I turned toward the medical profession, and particularly looking at hospice, because that is where I found myself. And at that time, and increasingly, I would use sympathy and empathy, because with the sympathy, I found that it was a way for me to gain the time and the patience to allow the patient to express his or her pain, his or her suffering. But the empathy allowed us to transform from that sympathy into an environment where they could feel themselves in the whole and see themselves beyond the pain. And at that point, we were able to introduce aromatherapies or music or something that would alleviate the suffering temporarily. But that was through holistic listening. And then as I became an administrator, using the talents that I had in the business and political world, back to this idea of empathy, where I'm listening to individuals from different aspects of healthcare and life care, advanced beginning care. And in order to coordinate that, I found that they empathetic to issues that they are experiencing as workers and administrators and managers was very helpful in building collaboration. So it's really quite a tool if you can see all of the aspects and the dynamics of it.
Great. Thank you for that response, and thank you for the definition, Dr. Halpern. That was very fruitful for this discussion. Does anyone else have any examples or thoughts about how empathy specifically helps them to engage, or where they feel that it could be increased?
It's really garbled. I'm having a hard time understanding what you're saying.
Okay.
Could you repeat that, please?
Sure. I was just asking if anyone else wanted to speak on the integration of empathy in their work. If there was anything additionally, any examples or situations that you would find relevant to mention here.
I'm sorry, I didn't catch the last part of it.
Any additional connections between your work and empathy that you find relevant to mention here?
I think that Jody mentioned listening, and my experience is that everyone likes to tell their story, and that part of relationship building is sharing stories. You know, when you think about going out on a first date, most of the time there's a lot of sharing stories and getting the other person to know who you are. And I find that to be an extremely important and very rewarding part of the work that I do. Oftentimes I will sit with a parent for long periods, an hour or more, simply listening and sharing their story, appreciating their story. And I think that when you're able to do that, and I think in medicine a lot of times these days, people are short on time and you really can't build that relationship. And I think one of the things that I really love about doing palliative care is having the almost luxury, as it were, to be able to really get to know people, to really be able to listen to their story and try to, we talk about walking that journey with them. And sometimes that sounds trite to me because you can't really walk that journey with them. But in some ways you can, simply by getting to know them and trying to kind of get inside their skin and try to imagine, as you said, Jody, about what it's like to be them. And I think if you don't have that component of your personality involved in palliative medicine, you'll never be able to give families what it is that they really need and want during that journey. Because ultimately, I can't change the outcome. I can't change the fact that their child is dying and that their child will die. But what I can change is their perception of that. And I can certainly change, or I can have an impact on their bereavement after the fact. And I spend a lot of time with parents who come back to George Mark Children's House. It's after the death of their child. It's really quite interesting to me that most bereaved family members don't want to come back to a hospital. Most of them don't want to go back to the physical setting where their loved one perhaps suffered and ultimately died. But at George Mark, it's really amazing to me that many families do come back, and they come back, I think, because of the personal connections that they've made here. I remember the first time that we were having an event here. We have a lot of events throughout the year. And I remember the first time a mother was coming back. She was bringing her other two children with her. And I assumed that she was coming because of the children, because she felt that that was the right thing to do for the siblings of this child who had died. And this child had died under unfortunately, or at least had suffered the injury that caused her death, it was an accident. So there was guilt involved, there was blame, there were second questions. It was something that didn't have to be. And I just assumed that this mother would be really reluctant to come back here. And so my assumption was, and you should never make assumptions, this taught me a lot, that she was only coming back because of the other children. So as I saw her coming up to the house, I went out to meet her before she came in the door, thinking that perhaps I could comfort her and be there to support her emotionally as she came back into this house where her child had died. And I said to her, it must be very difficult for you to come back. I'm here for you. I will do whatever I can to make this a little bit easier. And she immediately brightened up and said, no, I've been looking forward to coming back. This is where my daughter was. I have a lot of good memories from this place, not just the place where my daughter died. And I was so amazed, I practically fell over. I was absolutely blown away that was her response. But in fact, it was. And I've heard that from many, many, many other families, that even though the most terrible thing that can possibly happen to you in your whole life happened right here at George Mark Children's House, they do come back, and they are comforted by coming back. And part of that, I think, too, is the fact that we remember their children. We have several things that we do here on our grounds to remember every single individual child. And I think that parents, what they tell me is, I don't want my child's life and death to have been in vain. I don't want it to be forgotten. I want them to have made a difference. And when somebody has made a relationship with you and with your child who's now gone, that's important to parents, that their child is remembered. And I'm not quite sure how that ties in with empathy. I think maybe it's the empathy on the caregiver's part that allows us to make those relationships that we then can provide to those families going forward. But for me, that's an incredibly important part of the work that we do.
I did want to add just one story here. We had a couple of years ago, we did something called the Empathy Healthcare Cafe. And we had about 40 people who came here in Berkeley to talk about empathy and healthcare. And one of the questions we asked was, tell a story of where you experienced empathy in healthcare. And we had small table discussions, 4 to a table, and they would talk, and people were sharing stories about, my mother died. We were at the hospital, and the administrators were so caring, and they just showed all this emotion and concern and really heard us. And they were like in tears telling those stories. And the same thing was, we had some home care. We had someone come into our home, and they became like family, and they just, so I just saw how important that sense of caring was in this end of life situation.
I think you're absolutely right, Edwin. And that actually brings me to my next question, which has to do with your field, Dr. Halpern, psychology. And the question is about countertransference. And maybe psychiatry would be a better term to use. But countertransference postulates that the medical practitioner's feelings, the counseling practitioner's feelings are intertwined with the patient's feelings. And my understanding is that this typically happens more in a therapeutic situation. But I'm wondering, based on your experiences, Dr. Halpern and Dr. Beach, and also Marilyn, if this is also true in a hospice or palliative care setting, and if so, how are medical practitioners able to insulate themselves from the emotion involved in a field where your patients pass away?
I want to speak very briefly because I'm aware, Marilyn, that you had, speaking of listening, I saw your face earlier that it looked like you had an example in the last one, and I want to make sure you get a chance to talk about what you might have wanted to say then, okay? But maybe I'll just say something. Should I say something here and then let you two, maybe you go next? Is that good? Or do you want to go first? Either way.
No, you go right ahead. I'm interested in your response. You wrote the book.
Yeah, well, we could all, this is a group where we could have written many books, all of us.
But it's
And it is relevant to death and dying, which all three of you, as well as Edwin now from his project, but Marilyn, Kionis, and Barb have dealt with quite a bit. So I'll just say something very brief, and then everyone else can comment from their own examples. But I just know the research that's been done on something that really surprises a lot of doctors. Doctors still believe that they're supposed to be detached and that that's better for patients. And, gradually medical students are being trained differently, but still. It turns out that the lowest burnout area of MD medicine, it's in nursing, there's various trends, but the very lowest burnout is in palliative care. And then the lowest burnout group setting is hospice. So for nurses and doctors and social workers and others. So basically we see that it's around death and dying that we see the least burnout of all things. Of preventive medicine, sports medicine, you name it. So that is such a paradox. And I think that is because those are groups of people who have worked together. Well, first of all, too many doctors work as lone cowboys and they're not honest about or encouraged to share their feelings with anyone else. Palliative care settings, as all of you work in, you have to work as a team. Other people, other caregivers care about each other so that who you are as a human being is part of the day-to-day work. There's encouragement to become better and better in your empathy skills. And it's been looked at. There's something called measures of exquisite empathy, which is people who are just really good listeners and connectors, as I think the panel members here most likely are with patients and their families. And that seems to, again, predict the lowest burnout. So I've spent my career trying to show people that the most seemingly neutral, detached physician is just as emotionally affected by patient suffering as the ones that are able to do something with their humanity. That we don't escape other people's pain and suffering. We are all built socially to be attuned to each other's suffering. And so that to try to be neutral or detached is a waste of time and disserves the patient. It makes the patient actually feel quite disrespected when you're neutral in the face of their suffering. So that the skill of caring for your own emotional reactions, taking that to be part of your job, is to know how you're feeling as much of the time as you can. There's lots of tools to very quickly do things as simple as taking a deep breath, recognizing your sadness and taking a deep breath. It, believe it or not, has been shown in research to make a huge difference in your capacity to be with people and to listen. More advanced mindfulness kinds of skills help a lot, but I think just having a caregiver team member, when you can leave a room and look at them and say, wow, this is hard. Anyway, I'd like the other caregivers to comment about it on the panel, but the research shows that being very involved emotionally with patients and families, if that's encouraged and seen as appropriate to your role, if your colleagues respect it and you work together with them, makes your career more fulfilling, not more difficult.
Dr. Halperin, I had the pleasure of reading your book, and thank you for writing.
Oh, thank you.
And in the book, I read that physicians have a rationale for what they consider to be detached concern. They feel that is needed to care for the patient in an equal and impartial way. But then you go on to indicate that with managed care and the fact that physicians have to allocate their time and their treatments, that physicians still may have prejudices toward people whose values and backgrounds are distinct from their own. And I thought that was a very important point because I coupled it with some research that was published by the California Healthcare Foundation in their studies on differences in care experienced by ethnically diverse populations. And it concluded that care in those communities that are different and inequitable. And it's particularly examples that there is instances of undertreatment of pain for people who are elderly, poor, and are of racial and ethnic minorities. And also that family support and bereavement programs are less likely to be offered to these groups. And so that really heightens the importance of empathy and sympathy at a time when you're less inclined to give it because it's not coming from you naturally and socially as you are not identifying with this person who's in front of you. So it really heightens the need for people to understand distinctions between sympathy and empathy, to understand that that every person, we have to say to ourselves that every person is just like me, that's seeking happiness in his or her life, that every person is trying to avoid suffering, that every person knows sadness and loneliness and despair, and that every person is trying to fulfill their own needs, and that every person is learning about life as we go.
Thank you.
Yeah.
Thank you. Dr. Halpern, did you have a comment to that?
Well, yeah, I just have to say, I really agree with what you just said, and I think, what Marilyn spoke, and please call me Jody. I'm calling you Marilyn, so I want to be. At the time the book came out, I think I cite the study, the lung cancer study, which was so important, just showing that. I think it's in the New England Journal in like 97, 98. There was a study showing that most lung cancers, unfortunately, are not treatable. But there's a kind that is treatable through surgery if it's caught early. And that, it turned out that outcomes for African American patients were, in terms of having surgery in a timely fashion and surviving, were significantly lower if they had a white physician. And it was a group of physicians it was in Boston. It was a fairly progressive social environment for intellectually, but there was really, we don't know what went on in those doctor-patient specific interactions, but there's a lot of reason to think that this is the difference between sympathy and empathy. The very specific thing is that the surgery was called experimental at that time. And I don't think that my guess is, and this is somewhat speculative on my part, but I wrote about it in the book, that it's likely that when a white physician said to an African-American family, and these were all very educated families and physicians, we'd like to consider an experimental treatment for your lung cancer, that in the wake of Tuskegee and other things, we know that African-American families with predominantly white healthcare givers feel anxious when they're told about experimental treatments. So that's where empathy would matter more than sympathy, because you'd have to be curious, what are you hearing when I offer you an experimental treatment? So that's so interesting to me, that we really have to be curious, like, what does this mean from your background? So anyway, there's an example.
Thank you. So this actually leads me to my final question for the panel. Just the idea of, and Edwin bringing in the theme of your work, building a culture of empathy. Dr. Halpern, you mentioned that, Jody, you mentioned that that cultural influences do determine outcomes to a degree in terms of people's reception and access to particular medical care and health opportunities. And I'm mentioning that to bring up the study of work by Dr. Vijay Perrier-Cole out of Stanford on ethnogeriatrics. And that's a body of work that Comfort Homesake has been deeply engrossed in trying to develop connections between hospice advocacy and making sure that these culturally competent resources are available to all communities. Do you all have thoughts on ethnogeriatrics and why it's relevant, first in the medical field and also specifically in the hospice and palliative care realm?
We're all trying to give each other a chance. I want to make sure other people get a chance.
It's totally out of my realm of experience. So I think I understand what Dr. Perrier-Cole is talking about, but for my work, it's irrelevant if you want to say ethnogeriatrics. Now, if you want to say ethnopediatrics, that's a different story. And then I could relate to, I think that the most important thing you can do as a physician is to is to treat every other human being as a human being, the way that you would want to be treated were you in that situation. And I go so far as sometimes when I'm working with a family whose first language isn't English, I say to myself, what if I were in China and I didn't speak Chinese, which I don't, and something terrible happened to myself or one of my family members? How would I want to be treated? What would I want for myself? And I always, when I'm teaching medical professionals about palliative care, palliative medicine, what I always say is it's not rocket science, and 95% of it is communication. And when things go wrong in palliative medicine, it's almost always the communication that failed, not the medical piece of it. So I'm a firm believer in basically stripping away everything that all those I don't even want to say senses, but I want to say you need to strip away everything that looking at and being with that person tries to pop into your mind in terms of preconceived notions. Ultimately, this is a person who's another human being who is either facing or has had a loss, who is grieving, and you're there to try to help that person. And the rest of it is somewhat irrelevant. Now, I agree there are cultural aspects and you have to be very in tune to those, and those are important. But I think that you can also do too much of that. You can also kind of, it's hard for me to describe. I wanted to take a step back in terms of talking about caregivers and showing emotion. You talked, Jody, a little bit about physicians feeling like they have to be neutral and they have to, treat everyone in a certain way. Studies have clearly shown that if you can cry with a family, obviously you're not supposed to be so devastated that they're picking you up off the floor. You're there to support them, not them to support you. But I think some of my most meaningful moments have been where truly I can share my grief with them. It's not something that you should try to hold inside. That's when you burn out. Like you said, Jody, if you can acknowledge your grief and if you can respond to it and if you can share it, ideally you share it with your team members in palliative medicine. But there are times where you also can share it with family members. And there was a pediatric study where they interviewed, I think, 56 parents of children who had been withdrawn from life support in a pediatric intensive care unit. And they went back after the fact and they interviewed these parents about what was important to them. And they listed 6 things. And one of those was that the care staff relate to their child and to their work, not as a job, that they show compassion, that they show emotion, that they get into the trenches with those families. And it's okay to cry, and it's okay to express your sorrow and your empathy, because ultimately we're all in this together. Birth is terminal. We're all going to die. And I think that if we can acknowledge that and accept that, then we're able to then kind of put that aside and say, okay, I'm with you on this. I can't walk in your shoes, but I'm another human being who may well face that same thing that you're facing right now. And I can try to relate to that as much as possible. And I'm not just going to be this neutral person who's here to try to do my job. I'm going to be here as another human being who, at least on my own level, shares your sorrow, not the way you're feeling it. I'm feeling it differently than you are. But I acknowledge that there is sorrow, and it hurts me, it pains me, it makes me grieve too. And families, sometimes that's the best gift you can give a family, as long as you're not so devastated by your own reaction that you can't be there for them to do your job as a professional. But you don't want to just be that professional. You absolutely have to be another human being in their presence, being as compassionate and as empathetic as you possibly can be without it affecting your ability to help them. And that was a long, Jody.
Well, I just want to say thank you. I'm sorry, everybody, because I'm already late for teaching. When we picked the time, I always knew I had to leave just before 1. I've gone 15 minutes over because I'm so moved by what everyone's saying. So I'm so sorry that I could really participate much longer. I have so much I want to hear from all of you. I just want to say one thing, though. I do think that Marilyn and Barbara just now, in response to your question about ethnogeriatrics, Kionis, I think something that you both said, Marilyn and Barbara, that might be missed, the unity in it, is that it seems like it's very important to recognize that we all suffer ultimately. Marilyn, you said something about 20 minutes ago that was so beautiful about we all suffer ultimately in sort of the same ways. We're all human. Our co-humanity should not be invisible to people. Our common dignity across differences shouldn't be invisible. And what really worries me, and why I think ethnogeriatrics is a great field, and I'm worried about gender also in geriatrics, I've just been very involved lately with consults and people who have dementias and early dementias, and seeing how little regard people have for elders when they start to be cognitively impaired. And, there's just so many prejudices about everything from race to cognitive things to gender to everything that make us dehumanize each other. And so that's the thing to pay attention to. It's not so much that it's not so much mysterious each other's suffering. It's the unconscious prejudices that make us pay less attention to certain people. I see people not getting evaluations for reversible causes of dementia. There's sort of more and more, I think, going to be a prejudice in society because of the aging of the population and the increased, quote, burden of demented populations. I think there's going to be less and less engagement with helping people when things could be mitigated. So anyway, I wish we could talk more and more about everything from pediatrics to geriatrics and end of life. It's really an honor to meet each of you. I wish we were in person, though. I'm still not so much of a computer person. I wish I could shake your hands. Anyway, thanks a lot.
Thank you. Thank you,
Yeah.
Jody. Thank you, Dr. Beach. Thank you, Marilyn. Thank you all for your time today. Thank you, Jody, especially for staying over with us. I think, Jody, that you hit the nail on the head when you talked about this being the reason for us needing to build a culture of empathy, because we're all going to die. And at some point, the more that we can acknowledge that and put ourselves in each other's shoes, the more that we can support each other in that process and in those developments.
And if I may, I'd like to just quickly interject some data from the Bureau of Statistics talking about how America is aging. We're going to have, by 2030, 1 in 5 Americans over 65 years old. 84% of those people will suffer from one or more chronic disease and will require health resources. And many of those individuals will be living without cars and in poverty. And we've got to do something about our empathy for aging in America.
Yes.
So with that, thank you all for
Sounds like we need another forum. Honey.
Yeah, we can do it. We got the technology worked out now. I think it'll go smoother next
you.
time. So thank you so much, Kionis, for producing this panel and moderating as well.
Thank you.
So
Thank you,
with that-
Edwin. I'm hanging up, guys. I'll let you guys
Okay,
say
goodbye.
Thank you.
Bye, Jody.
Thank you. Bye-bye. Thank you.
See the world through other people's eyes. Empathy is a quality of character that can change the world.